Hello, and welcome to our online training on improving clinic operations, the importance of data collection. My name is Patricia Blackburn, and I'm a Vice President at CARDIA.
And my name is Johanna Rosenthal. I'll be joining Pat as a co-facilitator on this course. On behalf of the California Primary Care Association and CARDIA, we are pleased that you have selected this module to support your professional development.
CARDIA is a nonprofit, mission-driven organization with a principled team of committed and passionate staff. We have dedicated our careers to helping health and human service providers offer their best to their patients.
You see here on the slide the official mission of the organization. You may be aware that CPCA is offering this training as a part of their Patient-Centered Health Home Recognition Program. This initiative is for its member clinics to support their efforts to achieve Level 3 standards of National Committee for Quality Assurance Recognition. CPCA has made a commitment to support every member community health center to become a patient-centered health home. For more information, go to CPCA's website listed here. There are several handouts of the materials we plan to cover. It may be helpful to download and print those to refer to as you go through this course. If you haven't done so already, we suggest you stop the video and do so at this time. We'll let you know when it's time to refer to them.
There are 4 objectives that will give you a sense of what we're going to cover in this module. These are the things we hope you'll be able to do as a result of taking this course. First of all, you'll be able to implement a process to calculate the average patient cycle time. And secondly, you'll be able to implement a process to calculate the average provider productivity. The other 2 objectives that we hope you'll be able to do after this course is to collect other data points and to explore and document staff perceptions of patient flow. Before we get started on the data collection tools, we'll seek where collecting data fits with quality improvement and how quality improvement fits with the NCQA standards for a patient-centered health home. NCQA, as you probably know, has published standards for patient-centered health homes that include 6 standards and numerous elements under each standard. This course focuses on Standard 6, which is Measure and Improve Performance. Element A under Standard 6 is listed on the slide and covers such things as measuring your performance of preventive care, chronic and acute care, and the other items listed there. Element B under NCQA Standard 6 is Measure Patient and Family Experience. It basically states that the site needs to conduct surveys to evaluate the patient and family experience with access, communication, coordination, whole person care, and self-management. You need to be utilizing the CAHPS survey tool, which is a client patient experience survey. You need to be obtaining feedback from vulnerable populations, and you need to collect some qualitative feedback from patients and families. This particular element was discussed in a fair amount of detail in the module on patient satisfaction assessments. Element C in NCQA Standard 6 is Implement Continuous Quality Improvement. This is a must-pass element, meaning you must score at least 50% or higher on all aspects of Element C and other must-pass elements to achieve PCHH recognition. This element requires that sites use an ongoing quality improvement process to improve 3 measures from Element A, improve performance on 1 measure from Element B, address at least 1 disparity in care for vulnerable populations, and involve patients and family in QI activities. The approaches we are discussing today qualify as quality improvement activities in order to improve performance on Element B and potentially improve disparity of care. Element D and E of NCQA Standard 6 is Demonstrate Continuous Quality Improvement. This involves ongoing monitoring of the effectiveness of site improvement processes. Element E relates to reporting that performance. It means that you share the performance data with clinicians, staff, patients, and the public. So how do we define quality? First, it relates to the degree of excellence when measured against other health systems. Some of you may have heard patients say, "I now have a job with insurance, so I'll be going to a real doctor." Your services, particularly with the Affordable Care Act or Obamacare, will be measured against other healthcare providers, so quality is important. Quality means meeting or exceeding expectations. For example, many health centers are working very hard at reducing the waiting time during the clinic visit. Finally, quality is the degree to which the desired outcome improves. Knowing your desired outcome is critical. Your goal could be increasing access to those who need your services. Whatever the goal, identifying it and measuring your success is the key. So that's quality. Let's see what improvement is. You see here the definition of improvement. It's betterment and advancement, correction, enhancement, upgrading. The key again is to be able to identify what you want to improve and then be able to document that improvement has occurred. QI, or quality improvement, and QA, quality assurance, are sometimes confused. Let's spend just a moment to clarify the differences. They are connected and both are very important but different. You can see from this slide the comparison of the two. The biggest difference is that QI is driven by staff and patients, whereas QA is a management activity. Also, QI focuses on systems and processes, whereas QA tends to focus more on individual staff. Most of you already have quality improvement plans and activities. Our focus today is on collecting baseline data in order to identify if you need to improve the clinic processes and patient and staff flow or not, and if so, what areas need improvement. Just as a reminder, let's look at the key components of a QI plan. Here are some of the components of quality improvement plans. Leadership involvement means the mission, goals, objectives of the site support QI, and resources are provided for QI activities. QI teams, and they can vary, are empowered to do the work. They have the assignment, the timeline, and the time to do the work. It also is customer focused, meaning whatever we're looking at, be it issues related to clinical conditions or clinic processes and patient flow, the focus should always be on the patient. Quality improvement involves data collection. You need tools, indicators, benchmarks that are clearly defined so you know what to look at as a baseline and what to do on an ongoing basis to see if your improvements did what you'd hoped. That's what we're really focusing on today, is tools to collect data on your clinic operations. Process relates to how you go about implementing improvements. We have one process to recommend that you may already be utilizing called PDSA model. The plan needs to be continuous, meaning it's an activity where you look at the different indicators or processes on an ongoing basis. There are some basic steps in conducting QI activities. First, you set the aims. What are you trying to accomplish? Second, you need to establish the measures. How will you know that a change is an improvement? The course today on collecting baseline data is really to help you set your aims and define what you're trying to improve based on the data you collect. This process also identifies the areas you'll want to measure to see if the change improves the quality of patient care. The other steps in this QI process are things you'll do after collecting all your baseline information and identifying areas needing improvement. Those steps involve selecting changes you want to make to improve the issues you identify at baseline that need improvement. And finally, you need to test those changes. Again, we recommend the PDSA process. Many of you know the PDSA model, which is a rapid testing process where on a small scale you plan what you're going to change, you do or implement the change, you study what you've changed to see if it resulted in the improvement you hoped, and you act on what you learned to modify the change and repeat the PDSA testing until you get the result you're looking for. A review of potential changes you can make to improve patient flow will be discussed in a final module on strategies for improving clinic operations. We'll discuss the PDSA model in more detail in that module as well. You may already have some issues that you think are affecting the site's operation. Based on those ideas, what do you think your site's goal might be for improving your clinic operation? Pause the video for a moment and jot down your answers to that question. Hopefully you came up with some ideas for what your site's goal might be for improving the efficiency of your clinic operations. Here are some of the goals that other sites have set upon conducting quality improvement efforts focused on the efficiency of their patient flow clinic operations. You see on the slide the goal to see patients in the shortest amount of time possible. Sometimes sites actually set a time goal, like a total visit time of 60 minutes for all visit types. Some sites are trying to reduce the number of patient stops. Sometimes they identify an actual number as a goal, like no more than 5 stops during any visit. Here are some additional goals sites have identified after collecting baseline data. Patients spending as little time waiting as possible is one of those goals. In some cases, sites have established a particular percentage of time during the total visit that a patient will spend waiting versus seeing a person or staff. That goal is often no more than 40% of the patient's total time for the visit should be spent waiting. Another goal is reducing the number of handoffs to different staff. Those handoffs are always opportunities for the patient to wait, so if they are minimized, there is a reduced chance of patients waiting for staff. Reducing the site's no-show rate to a manageable percentage of appointed clients is often a goal. Some sites have come up with an actual percentage they're shooting for, like no more than 20% of the appointments will be no-shows. Other broader goals that sites sometimes identify may not relate to a specific issue, but focus on such things as increased access for more patients, utilizing the same number of staff that are currently available, or with a small increase in staff, or a goal of increased revenue from serving more patients with the same number of staff. In order to get accurate data to lead you to the site's goal for improving the clinic operations, you'll need to identify what's negatively as well as positively impacting your site's patient flow and operations. To that end, we'll provide data collection approaches during the rest of the course. We'll describe how to collect quantitative baseline data on patient cycle time and clinician productivity, as well as several other data points. Quantitative data are the numbers, the averages, and the observations. We'll also describe a process that will get staff involved in assessing the current practice model. This process is considered qualitative data collection, which means you're soliciting opinions and ideas from involved people, in this case, your staff. All of this data will help your site develop a goal for improving the site's patient flow and clinic operations. And just to note, some of the processes we'll describe are adaptations of materials from Coleman & Associates Patient Visit Redesign.
Let's begin by defining patient cycle time and clinician productivity, the baseline data that you'll want to collect first. Cycle time is the total time it takes for a patient to complete an entire visit in your facility. It is the total elapsed time from the moment when the patient enters to the time the patient leaves. Productivity refers to the number of patients seen over a defined period of time. You can assess the productivity of an individual provider or your clinic as a whole, or both. When is the best time to collect your data? In order to get a representative sample of your patient's cycle times and productivity, it's best to choose a week that's free from holidays. You also want to make sure that you have normal staffing, so definitely not when you have staff on vacations or out sick. It's important to use a sufficient sample size, so we recommend that you gather the equivalent of 2 full days of clinic patient visit data. It doesn't matter if your session time is split between days. For example, you could have 4 half-day sessions, such as a Monday afternoon, a Wednesday morning, a Thursday afternoon, or a Friday morning. And if your clinic has converted to electronic health records, you may already be collecting or have the capability of collecting cycle time data through your EHR system. So what data collection method is best? Electronic data or observation data? Bear in mind that it's important to capture the entire time that your patients are in your facility. So if your clinic ever has a line of patients waiting to check in at the front desk, or if patients are not entered into your electronic system until you call them up, we highly suggest you use another method for collecting arrival time. If you're not going to use your EHR system to collect cycle times, there are a number of different methods, and it's a matter of figuring out what will work best with your clinic systems, its physical layout, and your staffing. An example of a tool one can use to manually collect cycle times is this cycle time in-out tag shown on this slide. It is one of the handouts that is available for you to download. This shows 6 tags on one piece of paper, but 1 tag would be used for each patient. You can see that it's quite simple. There's a space for either the patient's ID or first name and last initial, today's date, and a box to check if he or she is a walk-in patient or if not, the appointment time, and then the visit type and the time in and out. Staff and patients can fill these out together. Staff who have been assigned to wait by the front door can fill in the arrival times and then hand the tag to the patient to fill in their own name, appointment time, and visit type. It will be important to very briefly explain to the patient that your clinic is conducting a patient flow study or time study to decrease wait times for patients and improve the patient's experience at your clinic. Staff would then bring the tag to the front desk where it would be attached to the patient's chart. Or, if your waiting room is not too busy, front desk staff might be able to watch the front door and document arrival times, making a brief descriptive note on the tag about the patient so that the correct tag is assigned to the correct patient once his or her identity is known after checking in. If there is no patient chart because you use electronic records, the patient can be made responsible for bringing the tag to the front desk upon checkout. The checkout staff would then fill in the departure time. Just know that you may not receive every single tag back, since some patients may lose it or forget to turn it in. As you receive each completed tag, or after you're done collecting cycle times for the day, transfer the data from each tag to this patient cycle time log Excel sheet. You'll see that there's a column for each field that was on the tag, as well as a final column on the right for you to write the total number of minutes the patient was in your clinic, otherwise known as cycle time. At the bottom of the log is a place for you to write the total number of patients and calculate the total of all the patient's cycle time minutes for that session using the Excel sum formula that we've circled in red above. Use these forms for each of the 4 sessions you've selected for collecting cycle time data. Once you've completed all 4 sessions, you'll need to calculate the average cycle time. Make sure that you do not find the average for each session, but rather you total the number of cycle time minutes for all 4 sessions combined and count the total number of patients for all 4 sessions. Then you'll divide the number of total minutes by the number of total patients. For example, we're showing you the very bottom of 4 patient cycle time logs with their total minutes and patients highlighted in yellow. To get the average cycle time, you'll add the patient totals you see on the left, which are 21 plus 21 plus 19 plus 20, and that comes to 81 patients. And then you'll add the total minutes for each session, which are 1662 plus 1842 plus 1687 plus 1786, and that comes to 6,977 total minutes that patients were at your site over the course of the 4 sessions. The next step is to divide the total minutes, 6,977, by the 81 patients, and you come up with an average cycle time of 86.1 minutes per patient. So your average patient visit lasts almost an hour and a half. If this were your site, what would you think? Satisfied, or would you want to try and move your patients through more quickly? Now let's talk about productivity, the other data we want to collect to form our baseline. As defined earlier, productivity in this context refers to the number of patients seen over a defined period of time, which is often measured per hour, but it could also be looked at per week or per month or per year. For our purposes now, in order to gather baseline data and then be able to make a comparison in the not too distant future, we're going to measure it per hour. Our measurement includes charting time as well. Whether it's end-of-the-day charting or charting as you see patients, this is very important time spent, and it can vary quite a bit between providers. As I said earlier, productivity can be determined for an individual provider or for your clinic as a whole, or both. Here is a productivity log that an individual provider would use to keep track of his or her time. This is also one of the handouts that you should have downloaded. There are 4 rows because we are suggesting that your provider track their productivity during 4 half-day sessions, just like when you're collecting cycle time data. As we take a closer look, you can see that there is a space at the top left for your provider to write the name of the site if your agency has more than one site, and a space for he or she to write name and license level. As you move from left to right across the column headings, we have a date and length of clinic sessions. So for example, the clinic might start at 9 and end at noon. There's time in, which is the time the provider was available to see patients, not when patients were actually seen, but when the provider was available. Here's why we're making the distinction between provider availability and actual time with the patient. Sometimes the provider is scheduled to begin seeing patients at 9 a.m. and is therefore available at 9, but the first patient doesn't arrive until 9 and is busy doing paperwork until 9:15, so the provider is kept waiting. Try to avoid these wasted minutes. Returning to the form, time out is when the provider has finished seeing patients, including the time spent charting. If the provider takes a break, he or she should punch out, so to speak, and punch back in on the log. The 4th column is where you calculate the total number of minutes during this session, and the 5th column is the total number of patients seen during this session. The final column is a place to write anything unusual that may have happened, or if the provider wants to explain why their productivity may have been lower than usual. Towards the bottom of this log, there are 2 spaces for totals that are highlighted: total number of minutes worked and total number of patients seen over the course of the 4 sessions. Since your totals are in minutes, you'll need to convert them into hours by simply dividing them by 60, and you'll see that the next row has a space for total hours worked. There are formulas built into the cells of these worksheets, so as you enter the number of minutes worked and patients seen, the totals will automatically appear and the minutes worked will be converted into hours. Then take the total number of patients, which is in cell E10, and divide it by the number of hours in D11 to get the number of patients seen per hour. Again, the formula is built into the cell, so calculations will automatically appear as your total patients and total hours worked are automatically filled in. Using this log form will help you determine an individual provider's average productivity. If you want to determine the average productivity of all of the providers at a particular site or at your agency, you'll want to use this Summary of Provider Productivity Logs, which is another downloadable handout. You can see that the column headings include date, provider name, number of minutes worked, and number of patients seen. So you would simply transfer the information and totals from the individual provider productivity logs to this one. At the bottom of the form, you total the number of minutes worked by all of your providers and total the number of patients seen circled in red. Once again, in order to convert the total minutes to hours, divide the total minutes by 60. To calculate the average productivity for all providers, divide the total number of patients seen by all the providers by the total number of hours worked. Again, the formulas are built into the cells, so as you enter data for each provider, your calculations will automatically appear. Let's return to an individual provider productivity log and look more closely at one that has been filled out. You can see that this provider, Eileen Conway, PA, chose 4 consecutive days in mid-November to track her productivity. She has documented 2 morning shifts and 2 afternoon shifts. You can see the start times and her time out, her total minutes per session, and the number of patients seen. The total minutes is 1,125, which divided by 60 equals 18.75, or almost 19 hours. If you divide the 57 patients by 18.75, you come up with Eileen Conway seeing an average of about 3 patients per hour. She has also included some notes about what may have contributed to the results. During the first shift, she saw a patient who came in on the wrong day, but because the patient had driven a long distance, she worked her in. The second shift had 1 no-show, and during the third shift, a patient's lab results were temporarily missing, so the visit took longer, and there were also lots of interruptions from staff. And during the last shift, many patients arrived late for their appointments. And here is a summary of provider productivity filled in with each provider's total minutes and number of patients seen. You can see that the grand total of 12,193 minutes worked automatically converted to 203 hours, and when divided into the 624 total patients, you get an average of about 3 patients seen per hour for your agency.
There are some other baseline data you can assess. These should be fairly easy to calculate. You see the suggested items on the slide. One is show and no-show rate. How many of your appointed patients come for their appointment? That's the show rate. The opposite is the no-show rate. The days to the next appointment. If I call today, how quickly can I be seen? The number of exam rooms. How many exam rooms do you have available on the day with the most providers? And finally, a mapping activity that staff will be involved in to identify routes, stops, and handoffs. Let's quickly look at how we gather these various items. In order to determine your site's appointment show rate, you're going to count the total number of patients who had an appointment, and you're going to count the number of patients who came for their appointment. Next, you will divide the total number of patients who came for their appointment by the total number of patients that were appointed. Here's a quick example. There were 45 patients who had an appointment. 30 of those patients came for their appointment. To determine the show rate, we divide 30 by 45, which gives us 0.67 or 67% of the appointed patients came or showed for their appointment. This example has a show rate of 67%. The opposite of the show rate is the no-show rate. To get the no-show rate, you count the total number of patients that had an appointment, just like before, and then you count the total number of patients who did not come for their appointment. You divide the total number of patients who didn't come for their appointment by the total number of patients who were appointed. Here's a sample of the no-show rate calculation. So you remember we had 45 patients who had an appointment. 15 of those patients didn't come for their appointment. To determine the no-show rate, we divide 15 by 45, which gives us 0.33 or 33% of the appointed patients didn't come or no-showed for their appointment. Calculating the no-show rate is often easier since there are fewer no-shows to count. You can then describe the result as either a no-show or a show rate. For example, if a site has a 20% no-show rate, it also has an 80% show rate. Another data point is the days to the next appointment. Our goal should be to see patients on the same day or the next day. We have learned, however, that the length of time to the next appointment affects the no-show rate. The longer the time between the patient calls and when the appointment occurs, the higher the no-show rate. To calculate the days to the next appointment, you need to review your appointment schedule on intermittent days for about 2 weeks to determine the number of days from the time the patient contacts the clinic to request an appointment to the next available appointment. These intermittent reviews of your appointment schedule document the number of days to the next appointment by each visit type. This could be urgent care, new patient physicals, routine exams, or whatever you choose. It also documents the number of days to the next appointment for each provider. To calculate the average number of days to the next available appointment by visit type or the next available appointment by provider, follow this approach. Count the number of days to the next appointment several times over a 2-week period. Add the number of days you found each time you reviewed the schedule. Divide the total number of days you found by the total number of times you reviewed the schedule. The result is the average number of days to the next available appointment. The slide shows we reviewed the schedule for appointments for a return visit 4 times during a 2-week period. The first review showed it was 5 days to the next return visit appointment. The next time we looked, it was 3 days to the next return visit appointment. The third review showed it was 4 days to the next return visit appointment, and our final review showed it was 2 days to the next return visit appointment. So we added the totals of 5 days, 3 days, 4 days, and 2 days to come up with a total of 14 days, divided by the number of days or times we reviewed, giving us an average of 3.5 days to the next appointment for a return visit.
How many exam rooms are available per provider? Is this true on the busiest days of the week or month? Count the exam rooms that are utilized and divide by the number of clinicians working. This example shows the site had 12 exam rooms. On the busiest day of the week, there were 8 clinicians working. The number of exam rooms per clinician is calculated by dividing the 12 exam rooms by the 8 clinicians for an average of 1.5 rooms per clinician. This calculation could be repeated for different days of the week to determine the number of exam rooms per provider that are available on a daily basis.
Another activity to conduct with as many staff as possible is mapping the patient route. This activity gives all staff the opportunity to step back and look at the routing of patients. It will help all participating staff's awareness of the patient's process and flow from the patient's perspective. Hopefully, they'll identify some areas that could be improved. Mapping should be done as a group. Ideally, all staff would meet together in one location to participate in the mapping activity. If that's not possible, small groups of staff could do the activity on their own in separate meetings. However, the final discussion of the results of those small group efforts needs to be done with as many staff as possible. As you see from the slide, the activity takes about 30 minutes. The materials you'll need is a ledger or easel paper, many colored markers, and ultimately masking tape. The initial work of mapping is done in small groups of 3 to 5 people. If you do this activity during a meeting with staff from multiple sites, create small groups made up of team members from the same site. If you are doing the activity with staff from just one site, consider groups of staff with similar job roles. So all the clerical staff would work together and all the MAs would work together, etc. Create multiple small groups of the same types of staff if any small group is larger than 5 people. Each group gets a piece of easel paper or some other large piece of paper and 5 to 6 different colored markers. Let the group know they will be mapping the patient's route through their visit at the clinic. Small group's first task is to draw, to the best of their ability, and there are no prizes for beauty, the clinic layout. Be sure that everywhere a patient may go for service is represented in this blueprint or layout of all parts of the facility. If there are offices or administrative areas where patients don't go, they do not need to be included or identified. The next staff, as a whole group, identify all the various patient visit types seen at your site. Small groups can be assigned specific visit types, or all groups can do all visit types. The groups will need to select a different colored marker for each of the visit types they are mapping. The actual mapping is pretty straightforward. Groups will draw on their clinic layout the progress or route through the clinic for each assigned visit type. Again, each route for different visit types will be drawn in a different color. Be sure that they start at the front door with that patient visit and that they indicate every route and step from the front door to the final stop, whether it's checkout or something else. Be sure the groups draw any back and forth to the waiting room and all stops during the visit. At each place the patient stops, put a number. For example, the waiting room may be number 1, the front desk might be number 2, the exam room might be the 3rd stop, whatever. The small group should be able to complete the route mapping in about 10 to 15 minutes.
Here's an example of a mapped visit. The patient enters and checks in at the front desk. She then takes a seat. After a few moments, she's called up to the front desk and handed paperwork. She returns to her seat to fill out the paperwork. She's soon called by the patient registration office, where she goes to discuss her insurance coverage and her copay and HIPAA policies, and she turns in her paperwork. She returns to her seat, and shortly after that, she's called by the provider to the provider's office to discuss the reason for the visit. She then is told to go to exam room number 2, and then is asked to go to the restroom to collect a urine sample. She then returns to the exam room, and then is asked to go to the lab for more lab work. She returns to her exam room one last time, before then finally checking out at the checkout desk, and then finally leaves the facility. The whole visit required 13 stops.
In order to process the maps that each small group created, all small group participants need to be together in one space. Each small group puts their map on the wall. Everyone else goes to one of the maps, and the small group explains their map. This process is repeated until all small groups have presented their map of patient routes. Each small group presentation of their map should take no longer than 3 to 5 minutes. We want to agree on the final route of each visit type, so if there are differences between the route or the number of stops for the same visit, discuss those as a group. For example, if one group shows 5 stops for a prenatal visit and another shows 7 stops, decide as a group which is correct. If a map from one group shows a different route for the same visit type, discuss and decide which route is correct. Once the maps show consistent routes and stops, you can discuss it as a whole group, such as how many total stops do patients make by visit type? Does the staff have any general thoughts about the patient's experience? Is there too much back and forth to the waiting room? Are there too many different stops? Or what else is going on? Ask participants if they were surprised by any of the information they saw, or whether they had any ahas. Again, the data from this activity can be combined with other data for a more complete baseline picture of where the site needs to improve its clinic processes to support efficient delivery of services to patients. We've discussed a variety of ways to collect quantitative data about the clinic operation. These are the numbers and averages we've discussed so far in this module, as well as another module on observing and documenting patient flow. The other useful information before you begin to set your goals for improvement is qualitative baseline data. This is data that's related to thoughts and perceptions. We have one short activity to describe that will foster input from staff that will be the qualitative baseline data that can be added to the quantitative data for a complete picture of the site's clinic operations. The activity to solicit staff thoughts is a brief, about 30-minute discussion conducted with all levels of staff at one time if possible, and is titled The Ideal Patient Visit. You'll work as a group with all of the staff. The facilitator of the discussion will need a flip chart with easel paper or a whiteboard and markers to document the discussion. As the facilitator, try to avoid interruptions and encourage the group to focus on the task. The facilitator should designate someone to keep time for 10 minutes. The timekeeper should give you a 5-minute warning and then interrupt when the 10 minutes are up. The question for the group is, what makes a medical visit flow? The question you are asking staff to answer is, when you are a patient, how do you want your visit to be? You're asking them to describe their personal desires for a medical visit. They can be as bold and creative as they'd like, but the bottom line is to ask them, if your visit could be perfect, how would it be? The group will brainstorm ideas. That means no judgments, anything goes. There should be no discussion about pros and cons of any idea. Participants are limited only by their own imaginations, so don't let them limit themselves. It will help if you encourage everyone to use I statements, such as, when I'm a patient, I want to walk into the clinic and that they'll know my name, or that when I leave, I don't have to stand in line to pay. Remember, everyone there is a patient at this visit. They know exactly what drives them crazy and what satisfies them about their healthcare visit. Go through the medical visit step by step. Don't forget about when you call for an appointment, or what happens when you arrive for the visit, or what happens if you need lab tests or x-rays. Reach broad agreement on each step of the process, but work quickly as a group and don't get bogged down. Describe your ideal visit and not how things work now. To process this discussion of the ideal visit, review the list of steps in the ideal visit and discuss how a visit at your site is different. Identify specific steps or stops at your site that could be improved to reach towards the ideal visit.
We've been describing key indicators, baseline data for you to collect and examine, all to help you determine how your clinic is currently doing in regards to being efficient, productive, and providing good service to your patients. We've discussed cycle times, productivity, show and no-show rates, number of days to the next appointment, number of exam rooms, mapping, all of which are quantitative data, and then we've described an activity you can do with your staff called the ideal visit to get some qualitative data, a great activity to get ideas rolling about what changes you might want to make at your site. The quantitative baseline data you will want to collect at another point in time after you've implemented some changes so that you can compare it to your original baseline data. We encourage you to review 2 other CPCA modules entitled Improving Clinic Operations, Observing and Documenting Patient Visits, which shows you a method for conducting detailed observations of a sample of patient visits to gain a better understanding of your clinic flow issues, and lastly, Improving Clinic Operations, Strategies and Best Practices, which will discuss potential interventions or solutions to clinic flow problems, as well as provide a review of key benchmarks and best practices. We hope you have found this module helpful and feel confident in moving forward with your efforts to make your clinic as efficient as it can be. Thank you so much for joining us today. Goodbye.